Part of what makes Prehab so successful is the precision. Different cancers have their own chemotherapy regimen, radiation treatments, and surgeries, so a good Prehab program is personalized to your baseline health and your treatment program. This is the third part of a full series on cancer prehabilitation. You can watch them in any order, but the first videos went through a general overview of how Prehab is structured and how it can benefit you. Swing back to those now after learning about all the main cancer types and how Prehab can be targeted differently for each of those. This one will be a great episode for patients and early trainees alike. So if you're curious how I would approach breast cancer differently from colorectal cancer or lymphoma or leukemia and others, stick around. My name is Dr. Alex Watson, and I get people ready. I take expertise in metabolic medicine and rehabilitation medicine, and I get people ready for major medical procedures. In this series, I'm sharing my best insights for prehabilitation before cancer treatments. And I'm also giving the Cancer Prehabilitation chapter of my book totally free below. The rest of the book is available on Amazon or Audible. My only minor request is that you give this video a thumbs up and subscribe. This way you can see when the next video is coming out in the series. Don't worry, they are all films. This won't be one of those channels that can't finish what it started. Helping others early in their cancer fight find this video will help them immensely. Please also read the disclaimer below, as this is not medical advice, it's for educational purposes only. I think at this point we should probably go through the main types of cancer, as it can be kind of word salad sometimes. So let's take a peek at the whiteboard here, and we'll be able to follow along with some of the names, okay? I was just trying to fix my doctor handwriting. Just kidding, my 4-year-old learned to write his letters here. Can you say prehabilitation?
Prehabilitation.
All right, so let's do a little bit of a fix here. Okay, there we go, much better. A little better, either way. Let's work with this. Sitting in my 4-year-old's chair. What were these cancer types? Even as a med student, there were plenty of times where it was tough for me to keep all the terms straight. Lymphoma, sarcoma, carcinoma, myeloma. So I'm hoping to put them all out there just to get a bird's eye view of all the different terms you might hear to make it a lot easier to kind of keep track of everything. Okay? All right, get started. So, carcinomas, these are cancers that begin in the epithelial lining of the organs and skin. So that's the outermost layer that's in contact with the outside world. So the epithelium of your stomach is the inner lining here that's facing all the stomach contents, the epithelial lining of your airways on the inside of the airway there. So the point of these is that they're rapidly turning over, and unfortunately in some cases they can become cancerous. Now these are some of the most common kinds of cancer because they make up breast, lung, colorectal, prostate cancers. They're all different forms of carcinomas. Adenocarcinoma is a very common term you might hear. During prehabilitation for these kinds of cancers, the focus is often going to be trying to manage the side effects of adjuvant or neoadjuvant therapies. So neoadjuvant therapies are things that we do ahead of time before surgery or whatever the primary therapy is to make that primary therapy more effective. So a neoadjuvant therapy is given ahead of time, say before surgery, to shrink the tumor down and increase the likelihood of just getting all the cancer cells out from that procedure and improve the chance of cure or a much better outcome in the end. Okay, so moving on to sarcomas. Sarcomas are cancers arising from connective tissues. So things like bone, muscle, fat, cartilage. Common ones here will be osteosarcoma, that's a bone cancer. Chondrosarcoma, that's a cartilage kind of cancer. So the prehabilitation focus before treatment for a sarcoma, it's going to be something along the lines of strengthening a limb before part of it is amputated because of a osteosarcoma or something like that. Essentially, you want to build as much muscle around that affected area, improve the overall health of metabolic health and everything so the surgery goes smoother. But the main focus now is really going to come after that, because a lot of times, say there's a osteosarcoma of the femur. Now, the biggest priority after the initial remission is achieved here is going to be getting a great prosthetic for that leg. So the specific concerns here are going to be related to mobility and then pre-prosthetic training. So that's after the amputation, before the limb is ready for prosthesis. You'll be preparing all the muscles, controlling your hip girdle or controlling whatever the residual limb is, or of course the opposite limb, making sure that one's extra strong, stable, and injury-free to be able to support the other limb while it's healing and all those sorts of things. Afterwards, prosthetic training is going to be the next stage. So you've gone through the pre-prosthetic training, the limbs healed up. Now you work with a prosthetist and get a brand new prosthetic limb made, and training how to use that as a big part of rehabilitation. So after the fact, okay? One final specific concern here. Pain management is often a bigger component than kind of the average treatment course, just because of the various different types of pain that might be involved. The phantom limb pain, post-surgical pain, kind of bony type pain. Those things require different approaches and, a very comprehensive skill set of pain management techniques. Okay. Moving on to melanoma. So melanoma, most folks are aware of what this is and can wrap their head around the concept. But basically, it's a cancer of the pigment-producing cells in the skin. These cells are called melanocytes. And the prehabilitation focus for treatment for melanoma relates a lot to kind of preparation for lymph node dissections and preparation for immunotherapy. So anytime you're going to have lymph node dissection, you have a risk for lymphedema. Depending on where this is occurring, it may involve strengthening all the muscles in the affected limb. And this way you have that muscle pump kind of action to help move lymph fluid out of the limb now that the network of lymph nodes and lymphatic drainage is affected there. So by strengthening the limb and really improving the overall health, you can then support it afterwards when its normal mechanisms are impaired. Immunotherapy is a phenomenal new branch of treatments that we have at our disposal for cancers. And melanoma is one of the major success stories here because it used to be universally a very, very grim prognosis and now has the opportunity for being, curative therapy in some cases. Unfortunately, immunotherapy is not without its unique risks and issues here, part of which is you're ramping up the immune system effectively. So you have a higher risk of developing autoimmunity. I've certainly seen cases of things I had never seen in other contexts, autoimmunity against facial nerves, things like that. But risk-benefit wise, for many, the benefits far exceed the risks. Okay, so that briefly wraps up our introduction to melanoma. Moving on to lymphomas. Now, this is one that the word salad on word salad inception here goes pretty extreme. So there are two main types of lymphoma. So lymphomas are divided into Hodgkin and non-Hodgkin for a number of reasons here. They have, key differences in their behaviors and cell characteristics, and the treatments can be quite different. That also means, of course, the prehabilitation can be quite different. So the cell origin, getting way into the weeds here, but just to briefly kind of get how it's different here. Hodgkin lymphoma usually originates from B cells. B cells produce antibodies. It's a big part of the immune system. Really important, of course, for our acquired immunity. So you get sick, your body develops antibodies, able to then maintain kind of a baseline level of adaptive coverage against that same infection later. And so these cells are the ones that kind of become this Hodgkin lymphoma. Now, non-Hodgkin lymphoma, they can kind of arise from B cells, T cells. T cells have their own unique adaptive and innate benefits here, or natural killer cells. Natural killer cells is another part of the immune system that go around killing bad stuff. Pretty cool. The pattern of spread of those two types, non-Hodgkin and Hodgkin, are both kind of unique here. So Hodgkin lymphoma has a pretty predictable pattern where it jumps from one lymph node group to an adjacent one. So it moves kind of geographically. Okay. While non-Hodgkin, it can kind of do what it wants. That's more of a random pattern. The prognosis for these also variable. And then within non-Hodgkin, because it's an umbrella term for many different types of lymphomas, it can be a bit more distributed and variable here. But for Hodgkin lymphoma, typically a better prognosis. We have kind of established treatment protocols to which it responds well. Where non-Hodgkin, because it's more than one entity, it's variable in terms of it. Some are very treatable, some are not quite as treatable. The age at which we get these is different too. So Hodgkin lymphoma has a bimodal distribution. You have a group of young adults and then older individuals who get this, and not as much in between or on the bookends. While non-Hodgkin increases as age goes on. So because of this, prehabilitation for non-Hodgkin tends to be geared more towards the frailty side of things because the patients are usually older adults, whereas Hodgkin can be a little bit of a younger skew. In this case, it might be a different approach here too. So in general, the prehab focus for all kinds of lymphoma is going to be overall conditioning, nutrition support, fatigue management, general sorts of things like that, because these tend to just have that kind of rundown, what we call B symptoms, night sweats, fevers, that kind of stuff. The bigger concern here is because you're affecting part of the immune system, the infection risk is higher when you're both afflicted by and receiving treatment for lymphomas. Okay. So from here, this is where the Prehab approaches are going to split, and we can get into specifics for Hodgkin lymphoma because those treatments are more standardized, whereas for non-Hodgkin, we're going to need to kind of give some generalizations, and I'll give you a few specific different subtypes too. I get my little person chair. Okay. So for Hodgkin lymphoma, prehabilitation is going to focus on a few specific symptoms and systems because this is where the knowledge of the different chemotherapies that are most common kind of come into play in terms of what we can anticipate as being necessary to kind of fortify ahead of time. So because a common chemotherapy agent, bleomycin, is used for Hodgkin lymphoma, we want to focus on cardiopulmonary training because it has known toxicity to the lungs. So getting the best aerobic capacity ahead of time is important, again, to just maintain the function of the respiratory system, but also improve the efficiency of the body to utilize the oxygen that it's getting. So you have less shortness of breath and fatigue and that sort of thing with basic activities. Given the bimodal distribution, we're going to focus on younger patients here. And so because of this, we can get theoretically more aggressive in terms of high intensity interval training to quickly bring up aerobic conditioning, VO2 max, those sorts of things. We can work on muscle mass a little more aggressively, again, because we might be starting from a higher baseline. And so you have that kind of luxury when treating Hodgkin lymphoma. But also because of this, fertility is a bigger concern. So a kind of pre-treatment fertility counseling and potentially banking sperm or eggs, that kind of thing ahead of time, just because chemotherapy can meaningfully impact fertility afterwards. And you want to have that consideration ahead of time. So you're not worrying about that. You just focus on treatment, getting better, and getting on to life. Finally, nutritional considerations are going to be a pretty big focus here too. Not as much as it used to be, but because Hodgkin lymphoma often occurs in the mediastinum here, so lymph nodes in the chest, radiation to that area can affect the esophagus. You don't have as much esophagitis as we used to have, but in this case, you want to make sure that you're able to, like we said earlier, find a nutritional supplement that you like. Find a one or two. So you have plenty of options here in case of taste change or swallowing difficulties or whatever. But then we also want to really find ways to fortify your kind of reserves ahead of time too. So getting those deadlifts in ahead of time, high calorie diet, build some muscle without worsening metabolic health. So not too high calorie of a diet, but really put on some muscle in there ahead of time. So if you do lose a little bit of weight because you can't eat as much, it's going to be still bring you down to a higher baseline than you had before prehab. Okay. Now, for non-Hodgkin lymphoma, prehab might emphasize a little different of a focus here. Again, the interventions will be age appropriate. So in this case, since it's skewing on the older side, balance training, resolving frailty as much as you can ahead of time will be a big priority here because you want to worry about things like other medical comorbidities that you just accumulate with age and thinking about how much more vulnerable that makes some of patients in that population before they receive chemotherapy and sort of aggressive treatments for lymphomas. Now, again, some of the unique chemotherapy considerations for prehab for non-Hodgkin lymphoma types of lymphoma, we're going to focus on a few areas. One of which is that anthracyclines, medications called doxorubicin. This one, you want to also be focusing on cardiopulmonary training, but because it has more of a cardiotoxicity. So if you're going to risk cardiomyopathy, so if you're going to risk cardiomyopathy, damage to heart muscle, you want to, again, make sure that your body's as able to extract nutrients from whatever blood it's getting so that the heart doesn't need to work quite as hard, or you can, accommodate for a heart that can't work as hard and won't work as hard. Another common medication used here will be vincristine and similar medications. And that's relevant because those are notorious for causing neuropathy. So between the older population and this potential for acquired neuropathy, prehab is going to focus a lot on balance training, building as much muscle as possible to fortify all the different bones and joints and everything, and proprioception. So being able to be aware of your body and space and that kind of thing. So some of the training here will be making sure that if the person is in reasonable good health ahead of time, well, then you can do some sort of like power training or things like that for quick reaction time and maximizing the chance to recover after a stumble in the event that you lose some sensation in your feet and can't really tell where your feet are in space just by the sensory impact. Because of the immune function being impacted by both the lymphoma and the treatments, you want to do whatever you can to optimize all the other things that feed into immune function. So optimizing sleep, optimizing mood, because depression will actually affect your immune system, finding the right combination of exercises that are both tolerable and enjoyable so that you can stay consistent with those sorts of things and really optimize all the other factors that go into a nice, healthy immune system. But for non-Hodgkin lymphoma, we can't be fully comprehensive because that would be a total hour in and of itself of going through all the different types, all the different treatments, and all the different potential side effects here. In general, though, you're deliberately giving systemic chemotherapies here to be able to prevent the spread of lymphoma around the body, other lymph nodes. And so think about the impact it can have on just overall wellness and vitality and immune function and start there. Okay. So made it through those two. Leukemia. So this is where it gets kind of murky because with leukemia, it's the blood-forming tissues, whereas in lymphoma, it can be some of those blood cells themselves contributing to. So understandably, I'm not going to bust your chops if it's you kind of mix up lymphoma and leukemia here, but it is pretty relevant because leukemias are obviously an entirely different beast. So again, these commonly originate in the bone marrow. That's where your body's starting to produce its different blood cell lines here, red blood cells, white blood cells, all that kind of stuff. And some examples here are going to be something like acute myeloid leukemia or chronic lymphocytic leukemia. So those relate to different cell lines here. Lymphocytic being lymphocytes or myeloid being myelocytes. Those are important to understand that because of where it goes when they mature into normal cells. So the prehabilitation focus is going to, again, kind of focus on just general overall vitality and resilience and those sorts of things and all the factors that go into a healthy immune system because, again, you're going to be affecting your immune system, but also anticipating things like anemia that can be much more common in this case or platelet issues and so bleeding risks and things like that. The biggest concerns are kind of what I just said here. So bleeding risk, prolonged hospitalization, in some cases because of the effects of treatment or the illness itself, the severe fatigue that comes from these kinds of cancers. Typically, we're going to be breaking this into acute and chronic leukemias. And all else held equal, acute leukemias are considered more serious, but it doesn't mean that all of them are inherently a very grim prognosis, nor does it mean that a chronic leukemia is a walk in the park either necessarily. Thankfully, treatments have gotten better in different types in both sides here, but I'm going to go through a couple of specific cases just to orient you a little bit here. So extending from there, between the acute and chronic leukemias, one of the better prognoses is when you have acute lymphoblastic leukemia in a child or young adult. Those tend to have better outcomes with potentially pretty good cure rates too. Another one with typically great outcomes is abbreviated APL or APML, and that's acute promyelocytic leukemia. And the reason why that has great outcomes typically is that it's a known common mutation between cases of APL, and because of that, there also was because of that, it just so happens that one compound is kind of the missing piece that's stopping that transition from that promyelocyte to a more mature and better normally functioning part of the white blood cell line there. So when the cells get stuck at that kind of checkpoint area, you can give this one medication. It's called ATRA, and the cell can then advance and effectively cure the problem there. And again, prognoses are going to be heavily dictated by the both the leukemia type and then the genetic subtype of that leukemia. So this outcomes are all over the field here. It can be very different outcomes based on kind of nuance that is even beyond my training here. All right, so as I said before, chronic leukemias tend to have better prognoses, but it's not guaranteed. Oftentimes, the prognosis is worst when a chronic leukemia converts to an acute leukemia, and then the rapidly forming cancer cells kind of crowd out healthy cells in the bone marrow. But two of the main types of chronic leukemias, CLL and CML, have unique features of their own here. So CLL is chronic lymphocytic leukemia, and that is a chronic leukemia of lymphocytes. Lymphocytes are the part of the white blood cells that typically fight viral infections and have other purposes, of course. And in this case, commonly causes an immune dysfunction called hypogammaglobulinemia, which just means you have reduced antibody levels. So obviously it's going to cause a pretty meaningful lack of immune response, and so you're at risk of opportunistic infections, and that tends to be a big part of the illness that comes with CLL. Now, as the leukemia continues to invade the bone marrow and crowd out those healthy cells, like I said before, you get causes of anemia, thrombocytopenia, which is low platelets, neutropenia, which is then a lack of neutrophils, which are really important for bacterial infection fighting. And when you have those situations, you can kind of guess what each one will kind of result in as a complication. These leukemias can also cause kind of lymph node issues as well, and other tissues related to immune system. So the spleen enlargement, painful swollen lymph nodes, those sorts of things, enlarged liver as well. And that could cause its own discomfort and functional issues as well. The one last kind of wrinkle here of things to be aware is that CLL often develops an autoimmunity. So one of the more common ones will be an autoimmune hemolytic anemia. So the immune system begins to attack red blood cells. And so you get this hemolytic anemia. The red blood cells hemolyze, they break open, resulting in an anemia after that. Similarly, there's a different condition where the immune system attacks platelets, and so it's thrombocytopenia. Alternatively, CML, chronic myeloid leukemia, causes some of the similar symptoms here. So splenomegaly, large spleen, that causes abdominal pain, early fullness when you're eating because the spleen is near the stomach and can cause you to feel full, and then other digestive issues as well. You get in this hypermetabolic state. So weight loss, night sweats, all those B symptoms I mentioned before, or you would generally call constitutional symptoms. CML is often identified incidentally, actually, on just kind of routine blood tests because it results in very high white blood cell counts. This is called hyperleukocytosis. So high leukocytosis, white blood cells. Whenever you have no overproduction of any sort of solute in the blood here, whether it be red blood cells, white blood cells, you can get this kind of sludging state. The leukostasis is what it's called in this case, because leuko being white, stasis. And that can cause, it depends on where that sludging occurs, basically causes effects almost like a clot. So you can have neurologic symptoms if it's in brain blood vessels. You can cause priapism in men, so it's an erection that you can't get rid of, and it's extremely painful and causes all kinds of secondary issues to penile function. If it happens to blood vessels in the eyes, so you can cause visual changes. Anything like that can happen here. So even if the platelets themselves are normal and the counts are normal, you can still get dysfunction of those platelets, and so they might not be working as well to stop minor, little cuts and things that you notice that can cause bleeding in the gums, sinuses, vaginal bleeding, all those kinds of things too. So that's also important to know. Now, both chronic leukemias can cause different metabolic complications, bone pain, and just really affect quality of life even without transitioning to an acute leukemia. So I don't want to downplay the seriousness of these, as they can be very symptomatic, but at the same time, many of them can be kind of stopped in their tracks or, put into remission. And so this is still an area of optimism. In the same vein of the optimism, subforms of CLL, many cases of CML, and then less common B-cell leukemias like one called hairy cell leukemia, they have some great prognoses. As always, the specific outcomes will be heavily dictated by the genetics of that kind of leukemia. But the beauty here is that as we get better at identifying the genetics and have AI to support us in terms of studying the abnormal proteins that some of these genetics produce, we can come up with better targeted therapies that may have fewer side effects and better outcomes. Okay, so that was kind of dense. Thanks for hanging with me. Multiple myeloma. So this one is a cancer of the plasma cells. And this is most commonly going to be affecting bone health. Very commonly going to have, different lesions in the bones, making bones prone to, but also the types of proteins that are produced with multiple myeloma can affect the kidneys. So in this case, electrolyte management, calcium management, this is going to be really, really important because the secondary effects of kidney damage can cause potassium issues. The calcium itself can cause its own issues and deposit it in places and cause all kinds of weird issues like that. Because this is a cancer in the bones, you can also have, very commonly an anemia can sneak up there. So a lot of interventions are going to focus on making sure that kind of levels of iron, folic acid, B12, that they're all well repleted. And we can maybe even get a little aerobic exercise ahead of time during prehab to just stimulate both red blood cell production as well as always, improve the ability of the body to utilize what it gets. So even if you do have anemia, well, if your body is just, reasonably well tuned up here, then it can work with that anemia better than someone who hasn't been doing that sort of preparation. Okay. Moving on to a very brief dive into brain tumors. So there are kind of two classes of brain tumors, really broadly. Ones that are primary in the brain and ones that get their secondary. So we're going to minimally talk about metastases of the brain because it's basically one of the other kinds of cancer that then went to the brain. But overall, these brain tumors, of course, have varied effects on the body and cognitive function and require neurological rehabilitation. The severity of the tumors range from fairly benign. So adenomas, meningiomas, these tend to be fairly benign, and the problems they cause are mostly because of the local impact, or sometimes they'll produce hormones. So pituitary adenomas, while benign in the respect they don't, metastasize and invade and all that stuff, they do produce oftentimes a hormone called prolactin, which can then affect hormonal levels of testosterone, estrogen, all sorts of things. So these are often found incidentally because someone is, of reproductive age and suddenly has fertility issues, and in the hormonal workup identify abnormal hormones, which then they will test for prolactin after that and find this hyperprolactinemia and go from there. Okay, so another common type of brain tumor, and these can be quite malignant, as you'll quickly realize I'm talking about, are astrocytomas, with the worst form, the highest grade ones being glioblastoma. So glioblastoma, that's what most people think about when they hear brain tumor. And these are the ones that have quite grim prognoses. John had passed away from one of these quickly, as did Ted Kennedy. When it comes to prehab for these and treatment for these, oftentimes the prehabilitation will be designed to improve quality of life and reduce caregiver burden. So just improving functional capabilities in the short term, with the understanding that if the cancer returns, progresses, whatever it might be, may affect function in whatever adjacent area. So that'd be motor function, cognitive function. It can block the movement of cerebrospinal fluid and cause problems related to increased pressure inside the skull, things like that. These often will require steroids, as brain swelling can be quite a problem in and of itself, even in the absence of the tumor being the primary issue at the moment. And so when you're on high doses of steroids, you can have other sorts of issues too. Seizures are not uncommon here, especially if the tumor then has a little bit of bleeding involved, as blood is irritating the brain. When it comes to metastases in the brain, there are certain cancers that very commonly metastasize the brain, or most commonly at least. These are going to be cancers like lung, breast, melanoma, kidney cancer, colorectal cancer a little less commonly. And then some other ones that can metastasize but don't do it quite as frequently would be things like testicular, ovarian, thyroid cancer. All right. Getting down the list here. Neuroendocrine. So neuroendocrine tumors are kind of what they sound like. They produce hormones a lot of times. So in this case, there will be a lot of metabolic and hormonal related considerations from neuroendocrine tumors. And as an example, one of them is called carcinoid syndrome. This is when a tumor produces a lot of serotonin and can cause symptoms like diarrhea, flushing, just general discomfort there. In general, Neuroendocrine tumors often cause gastrointestinal issues, so you want to monitor for certain deficiencies, if the absorption's been impacted here, or just general malabsorption, so you're going to have kind of malnutrition and wasting and things like that. But if you're considering the absorption issue, just think about kind of the different areas of the intestine and what can be absorbed there. So iron, folic acid, B12, really anything. One other kind of less obvious impact of Carcinomas syndrome is you can actually have accelerated heart disease, interestingly enough. So assessing cardiac function ahead of time and being mindful during prehabilitation of potential impacts on cardiac function when you're raising the heart rate and putting a little extra strain on the cardiovascular system. Other neuroendocrine tumors that have very specific hormonal features here include insulinomas, so a tumor that actually releases insulin. So if someone's suddenly becoming very truly hypoglycemic, not just you're getting a little jittery because you missed lunch, but like actual severe hypoglycemia, then you want to worry about, is there a tumor actually releasing insulin here? Quite uncommon. So again, if you're feeling a little shaky because you missed lunch, don't jump to thinking that it's insulinoma. That's not typically the cause. Similarly, there's another kind called a gastronoma that releases gastrin. Gastrin stimulates acid production. So these sometimes are identified when someone has recurrent ulcers with no obvious cause, not taking a ton of ibuprofen or something like that. Gastronomas then would be a concern there. Moving on to our last bucket here. And again, by no means is this list fully comprehensive, just trying to cover as many bases as we can without completely drowning you in more knowledge that you could possibly use. But gynecologic and testicular cancers. So gynecologic would involve things like uterine cancer, ovarian cancer, cervical cancer, things like that. Whereas for testicular cancer, there's a whole family of those as well. And each has kind of its own unique features here. So we're not going to get too deep in the weeds, but there's a couple important concepts with these. So for gynecologic cancers, obviously we'll be working in the pelvis. So pelvic floor disorders are quite common, and you want to be anticipating that in prehab. So kind of avoiding those sort of issues by doing the things we talked about earlier and we're going to talk about later, I'm sure. Deep squats, lunges, Kegels, all those sorts of things, just to get really good control of the pelvic floor. The idea is you want to reduce any risk of sexual dysfunction or incontinence later, and even pelvic pain too. So if we're going to pre-train that, we can avoid some of those issues. Because there will be lymph node dissection in the area too, we need to be really working on lymphedema prevention. So in this case, it can affect the legs because things drain this way, pelvis, all that. So again, working with maximizing muscle mass to have that external pump when the system is impaired in its normal function. And a lot of prehab, the benefits come from the education that you can provide. So just understanding what's coming, hence why I'm doing this whole thing. But understanding ahead of time what to anticipate removes the suffering aspect of it from being the primary concern. Because suffering comes from a lot of aspects of just not knowing, is it ever going to end? What's coming next? Knowing what to expect can greatly improve what otherwise is a negative situation. So understanding what sexual health concerns might arise and how to either, if this, do that kind of situation, those will make some of these secondary effects after different gynecologic cancers that much easier to manage and less kind of burdensome psychologically. So vaginal dilators, if you have any sort of fibrosis that causes painful intercourse, or lubricants, and if the person's of childbearing age and wants to maintain fertility, doing everything they can for banking eggs and those sorts of things. Now for testicular cancers, again, this time it's even more obvious. Sperm banking is really important if the patient's interested in reproduction, just because the whole point is to have treatment attack the testicle to get the cancer there. So fertility will be impaired. Oftentimes you're going to need to do some sort of testosterone replacement because there's not going to be a whole lot of testosterone production. Even if there is a testicular removal, understanding what ideal levels for testosterone are and how to, what signs of decreased levels are, and addressing that early can greatly improve health and just general wellness and everything like that. Identify a prosthetic too. After orchiectomy, which is the removal of the testicle, Individuals often opt for a prosthetic just to maintain the normal appearance of the scrotum and the genital area. So understanding that ahead of time removes kind of the surprise, which is an important part there for acceptance of the situation. Another unique feature in treating testicular cancer is that some of these chemotherapies have some ototoxicity, so they can affect your hearing. So based on hearing assessments and then being extra protective of hearing, so all those alerts from your phone about your headphones being too loud makes a lot more sense to follow those all of a sudden. Things like that. So, okay. That was a lot. Thank you sincerely for hanging with me through all those details. Again, please like and subscribe so others can find this resource during their cancer journey. If not already, the next video should be up within a week, and that one will be covering paraneoplastic syndromes. Essentially, when fighting cancer means fighting yourself. This one should have some medical mysteries in there too.